Okay, we're going to talk about mood stabilizers, and along with that, we will also talk about bipolar disorder. Bipolar disorder can be extremely challenging to diagnose. Bipolar includes both depressive and manic episodes of varying degrees of intensity, and we do have a number of different choices of medication that we can use to help with this. So we have a couple of case scenarios, and by the end of the lecture, you'll be able to respond to these scenarios. The first one, we have Sarah, who's 28, tells you she's been taking lithium for 4 weeks. Her dose was recently increased, and she tells you she has nausea, diarrhea, some muscle tremors, and finds it harder to concentrate. So what's going on here, and what would be your response? The second case scenario is Sam, who's 24. He was on Depakote at 1,500 milligrams daily. He did show some benefit, but complained of side effects. So his provider lowered the Depakote dose to 1,000 milligrams and started lamotrigine at a regular dose. What's the problem here, and what would be your response? So, bipolar disorder is characterized by 4 different types of episodes. Manic, which would be an abnormally elevated or expansive mood. Major depressive episode with depressed mood or loss of interest. A hypomanic episode, which is an elevated expansive mood, but less severe and shorter lasting than a manic episode. Or a mixed episode, which includes both a manic and a depressive episode going on at the same time. So major depression is the most common mood disorder, and it's defined by the occurrence of at least a single major depressive episode, although most patients will experience recurrent episodes of depression. Dysthymia is a less severe form of depression, but it is long-lasting, over 2 years in duration, and often unremitting. Oftentimes, patients will find that they feel as if their dysthymia is normal for them. In double depression, we have a patient with unremitting dysthymia who has a superimposition of a major depressive episode, and so this is described as double depression. In bipolar I disorder, we have the occurrence of at least one manic or a mixed episode, where in a mixed episode we have a full mania and a full depression simultaneously. Patients with bipolar I typically experience major depressive episodes as well. In a rapid cycling mania, there are at least 4 episodes of mania that occur within a year. There can also be more episodes than 4. In bipolar II, we have the presence of 1 or more major depressive episodes and at least 1 hypomanic episode occurring at some point in their life. Cyclothymic disorder is characterized by mood swings between hypomania and dysthymia, but without any full manic or major depressive episodes. There are also what we refer to as temperaments. So not all mood variations are pathological. Individuals with a depressive temperament may often be sad or apathetic, but they do not meet criteria for dysthymia or depression and don't have any functional impairment. We do believe, however, that individuals with a depressive temperament may be at greater risk for development of a mood disorder later in life. A hyperthymic temperament, in which the mood is above normal but not pathological, might include characteristics such as extroversion, optimism, exuberance, impulsiveness, overconfidence, grandiosity, or lack of inhibition. And individuals with hyperthymic temperament may be at greater risk for development of a mood disorder later in life. There is a huge variation in how patients with bipolar disorder present. This diagram is referring to the bipolar spectrum, and we see a variety of different levels of bipolar disorder delineated here. So there are a number of researchers that are promoting this type of explanation of bipolar disorder, including Dr. Kiskal. So oftentimes people will ask the difference between schizophrenia and a bipolar disorder. This is showing us the dichotomous disease model. So on the right side we see bipolar disorder, which includes mood cycling and mania. There can be a very good outcome. The person with schizophrenia also has psychosis. It is a chronic, unremitting disease with a poor outcome. And then we also see something called schizoaffective disorder, which includes psychosis, as well as affective changes such as mania and depression. First-line treatment for schizophrenia would be an antipsychotic, either first or second generation. First-line treatment for bipolar disorder would be a mood stabilizer. Mood stabilizer is not first-line treatment for schizophrenia. It is something that could be used to augment treatment, particularly if the person has a schizoaffective disorder. So the first thing you need to treat in schizophrenia or schizoaffective disorder is the psychosis. And that would be with the use of an atypical antipsychotic. Here we have schizophrenia and bipolar disorder presented as a continuum disease model. So there are different types of mood stabilizers. We have treatments that focus on mania. These are treating the problem from above and stabilizing the patient from above. We have treatments that are focused on treating the depression. These are treating from below and stabilizing the patient from below. So typical medication for bipolar disorder includes lithium and mood stabilizers, most of which are anticonvulsants or neuromodulators, antipsychotics, first or second generation, and possibly antidepressants. So there is some controversy about using antidepressants to treat bipolar disorder. They should never be a monotherapy, and if they are used, they must be used in conjunction with a mood stabilizer or an antipsychotic, and only if the depression has not been relieved by the first-line treatments. So screening is quite important in monitoring the mood stabilizing medications. So in all cases, you need to ensure that your patient is not pregnant. Both lithium, Depakote, carbamazepine, there should be pre-screening labs of CBC with a differential. The lithium should look at kidney function with creatinine and BUN, as well as thyroid function, TSH, free T3, and free T4, whether the patient is on NSAIDs, ACE inhibitors, thiazides, and so forth. So with all of them, you need to know what other medications your patients might be on, as well as supplements. So when lithium is first prescribed, a level should be then checked within 4 to 5 days. And then potentially you'll be increasing that dose to get an effective response. And then you will again recheck the lithium in 4 to 5 days. And then at the 1 month, or whenever there is a dosage change, or at least every 6 months. TSH should be checked again at 2 weeks, 6 months, and then annually. Creatinine and BUN every 6 to 12 months. The Depakote and the carbamazepine need pre-screening of the CBC with DIF, liver function, serum amylase. The liver function should be repeated at 2 weeks, 6 months, and annually. The CBC with DIF should be repeated annually. And a valproic acid level should be checked 1 week after the dosage change and every 6 months. Can also check a carbamazepine level as well. Lamotrigine doesn't require any pre-screening labs or any labs during therapy. You do want to make sure that you don't have a patient who does have a history of drug rashes. In that case, they might not be a good candidate for the lamotrigine. So we don't know lithium's exact mechanism of action, but these are our hypotheses of what the mechanisms might be. And so if we see the diagram on the right, lithium may work by affecting signal transduction, perhaps by inhibition of second messenger enzymes. Or lithium may work by modulating G proteins in the middle, or by interaction at various sites within the downstream signal transduction cascades on the left. So again, lithium blood levels must be closely monitored. Typically, I will do it every 4 to 5 days, and you would want to check a trough level, which is 12 hours from the last dose. Once you reach a therapeutic dose, then perhaps you check monthly and then every 3 months. You need to caution your patient to stay well hydrated in hot weather or with exercise, or if they become ill. You need to let them know of the potential for weight gain, to inform you if they have problems with thirst or frequent urination or fine muscle tremors. The therapeutic level of lithium should be 0.6 to 1.2 milliequivalent. If the person who's hitting 1.5 would likely present with GI upset, stomach discomfort, nausea, vomiting, diarrhea, tremors, lethargy, problem with their mental concentration, slurring in speech, ataxia, muscle weakness, or an uncontrollable eye movement. Hopefully, your patient reaches out at that point. If it should get to a toxic level of 2.0, your patient will be fatigued with muscle weakness, gross muscle tremors, slurred speech, psychosis, stupor, and at that point, they're going to be in need of hospitalization with hemodialysis, possibly gastric lavage, sodium-containing IV fluids. At 2.5, your person would be toxic, very toxic, with muscle rigidity, coma, renal failure, cardiac arrhythmia, and death. The treatments, there's no antidote to the lithium, so all you can do is lower the dose or stop it. So sodium-containing IV fluids would be added, and/or gastric lavage or hemodialysis. A person who has become toxic may need a great deal of time to recover. So you need to be careful about what other medications your patient may be started on, and don't assume that other providers will be aware of what drugs could interact with lithium. So, for example, lithium can increase NSAIDs, ibuprofen, etc. These medicines can all increase the level of lithium and result in problems with side effects and toxicity. It used to be thought that lithium should not be administered during pregnancy, but it is a risk-benefit discussion with you and your patient and the OB-GYN. So the perinatal period is a time of greatest risk for flare-ups of mood cycling. It is now thought that the risk of Epstein anomaly is much less than previously thought. You have to also keep in mind, if you're going to leave your patient on lithium during the pregnancy, is that there's going to be an increased GFR, and so that will require an increase in the dosing of the lithium. So the increased GFR results in a more rapid clearance of the lithium. So the dose will need to go up and need to be monitored closely. However, once delivery occurs, that GFR is going to drop rapidly, and so the lithium level needs to be adjusted quickly as well. Lithium during breastfeeding was also contraindicated in the past. It could be considered if the mom is stable on 600 to 1200 milligrams per day. The baby's serum levels would need to be monitored, as well as their kidney function and their thyroid function. But if mom is stable and the lithium is monotherapy, the infant is healthy, and a pediatrician is willing to monitor, then it could be considered. Some other things to keep in mind in managing adverse effects from lithium. So polyuria can be managed by increasing fluid containing salt, or the lithium dose can be lowered. Tremors, you might assess how much caffeine intake is occurring. Propranolol also can be extremely helpful. If diarrhea occurs, avoid the slow-released preparation or lower the dose, and monitor lithium level, as the diarrhea can result in lithium toxicity. Monitor for thyroid abnormalities. What may be normal thyroid level in people without bipolar may actually be abnormal in people with bipolar disorder. So thyroid may need to be supplemented. And then renal function, if the GFR should decrease or the creatinine increase, consider alternate treatment and/or consult with a nephrologist. Okay, so valproic acid, it's known by many different names: valproate, divalproex, Depakote, Depakine, Depakote sprinkles, Depakon. Valproic acid inhibits the enzyme that breaks down GABA, and it blocks reuptake of GABA into the glial and nerve cells. And so for those reasons, valproic acid is sometimes used to help with anxiety management. Valproic acid inhibits voltage-sensitive sodium channels, It's also involved in the production of a neuronal protective substance such as BDNF. It has also been found to be more effective when combined with lithium. Here we see the icon of showing us the pharmacological actions of valproic acid. It can work by interfering with voltage-sensitive sodium channels. It can enhance the inhibitory actions of GABA, and it can regulate downstream signal transduction cascades. It may also interact with other ion channels, such as the voltage-sensitive calcium channels, and also indirectly block the actions of glutamate. Here are the possible sites of action of valproate on the voltage-sensitive sodium channels. It may cause an antimanic effect by changing the sensitivity of the voltage-sensitive sodium channels, possibly by binding to channel subunits, or possibly by inhibiting phosphorylating enzymes that regulate the sensitivity of those ion channels. Inhibition of voltage-sensitive sodium channels would reduce the sodium influx and in turn reduce the glutamate excitatory neurotransmission. Here we're looking at the possible sites of action of valproate on GABA. So valproate's antimanic efficacy may be due to enhancement of GABA neurotransmission. And perhaps by either inhibiting GABA reuptake or enhancing GABA release or interfering with metabolism of GABA, we can get an antimanic effect. Here we see the possible sites of actions of valproate on downstream signal transduction cascades. And so valproate has been shown to have multiple downstream effects on signal transduction cascades, which may be involved in the antimanic effects. So we can see in this diagram that valproate is inhibiting GSK3, protein kinase, and MARCKS. In addition, valproate can activate signals that promote neuroprotection. We see the BDNF icon here, and long-term plasticity. So the valproic acid dosing is typically 1,000 to 1,500 milligrams per day, with the maximum dose being 60 milligrams per kilogram daily. It comes as an immediate release and extended release, which is typically once a day. The extended release can reduce the stomach irritation and may possibly reduce alopecia from occurring. So extended release, you can typically give at plasma levels 10 to 20% lower than the immediate release. You need to do the initial lab screening and ongoing monitoring. You can have lots of side effects from valproic acid: GI problems, weight gain, sedation, lethargy, hand tremors, alopecia, liver damage, pancreatitis, and thrombocytopenia. It should be avoided in women of childbearing age because it can and is known to cause neural tube defects. Lamotrigine is and can be very effective for the lower ends of the bipolar spectrum. So here we see the icon of its pharmacological actions. It may work by blocking the alpha subunit of the voltage-sensitive sodium channels. It could have action at other ion channels for calcium, potassium. And it's also thought to reduce the release of glutamate. Here we see the possible site of action of lamotrigine on glutamate release. It's possible lamotrigine reduces glutamate release through its blockade of voltage-sensitive sodium channels. It could also have this effect via other effects that we just don't understand. Your primary concern with lamotrigine is the Stevens-Johnson's rash. It is rare, but it can be fatal. The rash typically occurs in the upper trunk around the mouth and the eyes. If the person has the rash, it's also occurring in the mucous membranes of the mouth. The person may also have a sore throat. And so the dosing needs to be very slow, and you would start at 25 milligrams daily for 2 weeks, and then 50 milligrams daily for 2 more weeks, and then you can go ahead to 100 milligrams. Efficacy typically starts at 100, and it's usually between 100 to 200 milligrams. If you are going to use lamotrigine with someone who is on Depakote, the Depakote dose is typically left alone, or though it could be reduced. Regardless, the lamotrigine dose must be cut in half, and so you would administer 12.5 milligrams, which would be a half tablet, daily for 2 weeks, then 25 milligrams for 2 weeks, and then the target is 50 milligrams. And again, this is because the risk of Stevens-Johnson's is much higher. Here we see an icon of carbamazepine. It may work by binding to the alpha subunit of the voltage-sensitive sodium channels, and it may have action at other ion channels for calcium and potassium. By interfering with the voltage-sensitive channels, it may enhance the inhibitory actions of GABA. Carbamazepine is believed to bind to a site within the voltage-sensitive sodium channel. So carbamazepine can reduce neuronal excitation by blocking sodium channels. It could inhibit enzyme activity in the second messenger systems. It can increase the density of GABA receptors. It is thought to be better for mixed and rapid cycling mania, and it can also cause the Stevens-Johnson rash. It is absolutely not safe in pregnancy and causes birth defects, and it should be given cautiously or not at all in people of Asian ethnicity due to the allele HLA-B1502. Carbamazepine side effects include GI upset, sedation, ataxia, visual disturbances, Stevens-Johnson's, cognitive blunting, and blood disorders. So there's a lot of drug interactions with carbamazepine. It works through CYP3A4, and this can cause a decrease in the serum levels of other drugs, especially antipsychotics, including aripiprazole, clozapine, iloperidone, lurasidone, quetiapine, clozapine, and Vraylar. It also metabolizes itself, so it can be tricky to prescribe. Oxcarbazepine is a derivative of carbamazepine. It's very similar pharmacodynamic properties, although it's considered superior to carbamazepine because it is so easily metabolized by the liver. There's no CYP450 problems, very few drug interactions. It does, however, pass into breast milk, and the usage in pregnancy has not been determined. A couple of other drugs in use today that would not be first line for bipolar or mood disorders, but could be a second line choices, including gabapentin, 300 milligrams 3 times a day. Gabapentin blocks voltage-sensitive calcium channels. It's also used to treat neuropathic pain, and can be used as an anxiolytic when dosed 2 to 3 times a day. Another second-line choice would be topiramate, just Topamax, which can be given 50 to 100 milligrams daily or BID. This drug blocks voltage-sensitive sodium channels. It's frequently used to deal with weight gain caused by psychiatric medications. And so one of the side effects of topiramate is to cause weight loss. And so it can be useful in that regard. You do have to watch not to get the dose higher. When you get to about 300 milligrams daily, it's known to reduce cognitive functioning, and so it's been nicknamed Dopamax. So there are a number of different combination treatments for bipolar disorder. The ones we're looking at right now are evidence-based bipolar combos. So the first one would be combining an atypical antipsychotic with lithium. We've known that to be effective. We also know that combining an atypical antipsychotic with valproate also has shown efficacy. And the following are practice-based bipolar combos. The first one would be lithium along with valproate, or lamotrigine along with valproate, but with the caution of the very low level that you have to dose the lamotrigine. Lamotrigine and lithium has shown effectiveness. Lamotrigine, lithium, and valproate combined, again with caution on the dosing of the lamotrigine. And lamotrigine and quetiapine is often used in practice. Then we have something called geographic-based bipolar combos. The first one would be Boston Bipolar Brew. This is any combination, but absolutely no antidepressant. Second one is California Careful Cocktail, is any combination with an antidepressant. Third one is Tennessee Moonshine, which is an atypical and an antidepressant. This is a table just looking at some options. The high points of the items that can treat mania and depressive symptoms would include lithium, quetiapine, olanzapine. Lurasidone has not shown efficacy in treating mania. We know that using lamotrigine, omega-3s, or high-dose thyroid can treat depression without worsening the cycling. Treating manic symptoms and cycling would include Depakote, carbamazepine, oxcarbazepine. Things that can make bipolar worse are listed, so just to give you some ideas. So the atypical antipsychotics, when we're using them to treat bipolar disorder, the second generation are preferred. Olanzapine also has a combo of olanzapine and fluoxetine called Symbiox. Olanzapine can be effective for mania, quetiapine, mania and depression, aripiprazole, mania, risperidone, mania, lurasidone, depression, and some others that aren't on here would include Vraylar, which has been shown to treat whatever episode of bipolar the patient is having. Mechanism of action would be the D2 and the 5-HT2A blockade. Oftentimes an antipsychotic is used with a mood stabilizer. By using an atypical antipsychotic first, you will get a more rapid response to the mania, and then if still necessary, you can add the mood stabilizer. Of course, you need to continue monitoring. Here's just a little picture of bipolar showing the two different states in our patient. So how do you choose an anti-manic agent? Lithium can be a good choice. Lithium is also known for its anti-suicide properties. Divalproex and carbamazepine have been shown to have some extra efficacy in treating a mixed state, mixed mania. Carbamazepine can be tricky in keeping management of the blood levels. Lamotrigine is not an anti-manic agent. It can be an adjunct to an anti-manic agent. It's thought to reduce the risk of relapse and possibly prevent depression. And we talked about the differences between the atypical antipsychotics. Benzodiazepines might provide use as a short-term adjunctive medication for either sleep or agitation. So how long do you keep someone on bipolar treatment? So there are no controlled studies. One of the guidelines suggests that if this is a first-time episode with no family history, then continue for 6 months and then taper. But following a second manic episode, then treatment should be continued lifelong. The concern is that untreated episodes result in successive brain damage, and each time you start over treating, it becomes more difficult to treat effectively. So, do antidepressants work in bipolar depression? Well, depending on which expert you want to listen to, maybe yes or maybe no. We know that antidepressants can trigger mania. Question is, if a person is on an antidepressant and doing well, you could leave it. But if the person continues to have cycling several times a year, then it may be because of that antidepressant, and so it should be tapered off very slowly. Here's some non-antidepressant alternatives: exercise, CBT, light omega-3s, NAC, optimize thyroid function. So in general, don't use antidepressants unless the person has done well on them before, or if they've been on an antidepressant and then got worse when it was stopped, and never prescribe an antidepressant if there is not a mood stabilizer or a typical antipsychotic already on board. So our case scenarios: Sarah, 28, tells you she's been taking lithium for 4 weeks. Her dose was recently increased, and now she tells you she has diarrhea, nausea, muscle tremors, and finds it harder to concentrate. So what's going on here, and what would be your response? So it sounds like she's having side effects from the increased lithium level and may just be starting to have some toxicity. And so you would want to reduce her dose right away and get a level. Sam, 24, was on Depakote at 1,500 milligrams daily. He showed some benefit but complained of side effects. So his provider lowered the Depakote to 1,000 milligrams and started lamotrigine at a regular dose. What's the problem here, and what's your response? Well, the problem is that the provider started lamotrigine at a regular dose, which increases this person's risk of Stevens-Johnson syndrome dramatically. And so lamotrigine should have been started at 12.5 milligrams before being increased, and then maximum dose of 50 milligrams. Okay, so a couple of questions for thought. Which of the following medications would be the best choice for mood stabilization of a non-psychotic mania in a 10-year-old? Accutane, beclomethasone, lithium, divalproex, or risperidone. So lithium is the only mood stabilizing medication that has received FDA approval for treatment of bipolar disorder in kids older than 12. Okay, so it wouldn't be lithium. Divalproex has a long safety profile in young individuals because of its long history of use for seizures, even though this would be an off-label use. So your best answer here would be divalproex. Okay, and then a 16-year-old girl has been admitted with a 3-week history of sudden irritability, impulse buying, disappearing at night with older men. Her need for sleep is decreased. She has flight of ideas and grandiose thoughts about being an advisor to a presidential candidate. Test results indicate she is pregnant. Which of the following is a statement that should be made to her parents? A. Treatment with an SSRI antidepressant is a reasonable alternative to mood stabilizers in a pregnant girl. B. Given the fact that she is pregnant, she should be kept secluded on an inpatient unit during the first trimester of her pregnancy with no meds. C. An atypical antipsychotic may be the best choice for managing both her psychotic features and mood disturbance associated with her bipolar disorder, especially during the first trimester. D. Psychotherapy will have little role in the treatment of her bipolar disorder. Or E. Lithium divalproex and carbamazepine are all reasonable first-choice mood stabilizers for this girl. And so we know that keeping her secluded is not a good idea. SSRI would not be a reasonable choice. Psychotherapy will help her. And so the best choice would be the use of an atypical antipsychotic. And then there is a slide here. You could go to stallonline.cambridge.org, and there are some case studies that you can look at there.